I'm delighted to introduce our guest speaker for today, who's Dr. Peter Pirrie, who's a research and innovation manager in the NHS, but also a visiting fellow at the University of Southampton. Dr. Pirrie is a cognitive psychotherapist, and his particular area of interest is in the cultural adaptation of cognitive behavioral therapy. So, some large words there, but I'm sure during our conversation today, you'll get more of an idea of what we're talking about. We're going to be looking at the mental health and well-being of people from the African and African Caribbean communities living with diabetes. So, welcome, Dr. Pirrie.
Thank you. It's a
It's
pleasure to
really
be here.
good. Yeah, and it's really good to have you here. So, I think let's start at the beginning. In the communities that we're talking about, I know that your research interest is in African Caribbean populations, but also Asian populations and other minority populations. That's correct, isn't
Yeah.
it? Yeah. So, I mean, in terms of the Black African and Caribbean populations, what would you say with regards to talking about mental health? Is it something that people find easy to talk about in these communities?
Okay. So, I mean, what's interesting is that even though we are living in the West, where mental illness and stigma about mental illness is probably less, especially for us in the UK, when it comes to um, Black people or Afro Caribbeans and South Asian Muslim communities, the stigma of mental illness remains a taboo. And really, this plays a key role in how then people engage or interact with mental health services. So, what often happens if if it is a taboo to talk about mental health problems, people might not seek help. And when people don't seek help and they don't get any treatment, they become unwell, which might mean they result in presenting to services in crisis. And this is what then leads to them either being admitted either to acute hospitals and oftentimes under section of the Mental Health Act or basically involuntarily. And this is a very common pathway for people because and partly because of the impact really of stigma and shame as well, because those are some of the two key things.
And absolutely, we don't want people to be following that sort of pathway where crisis is the reason why somebody is admitted with perhaps a severe mental illness. I mean, I think what we're trying to do is to talk about mental health in its fullest form, um, make sure people are aware of the signs and symptoms that they should look out for, and perhaps their family should look out for as well, so that we can avoid those sort of crisis situations if it's possible to avoid them. And I think that, complexity is added to this when we look at the aspect of diabetes overlaying somebody's mental health and well-being, because the two things are so involved with each other, mental health and diabetes. So with regards to diabetes, let's talk about diabetes and mental health. um, in terms of diabetes and mental health, the main issues are things like anxiety, depression, eating disorders, which people who aren't living with diabetes, of course, can have.
Mhm.
But there is something called diabetes distress. And diabetes distress is different to that anxiety, depression, and eating disorder diagnosis, if we can put it like that. And my understanding, Dr. Piri, is that diabetes distress is about the almost like the exhaustion that can come of living with a long-term condition.
Mm-hmm.
And diabetes of itself can be quite demanding, monitoring blood glucose levels, being careful about what you're eating, trying to be more active, and constantly being aware of that. And so then that can, of itself, cause some exhaustion to people. And my understanding, in a simplistic way, is diabetes distress is an effect of that. What would you say?
I mean, obviously, there are two. I mean, there are differences in diabetes distress and clinical depression. I mean, in a simpler form, you can they're both measured using different tools. So, for instance, with depression, you can use the PHQ-9, which is commonly used in primary care, or in the psychological world. People might use the Beck's depression inventory to measure distress. But I suppose if someone at home, you can measure distress even just using simple subjective units of distress. How distressed are you feeling on a scale of 0 to 10? Not being not distressed and 10 being very distressed. I mean, this can be done by a family member. This can be done by the individual to themselves as well. Just measuring how distressed they are. Whether, as we say, is by repeatedly, taking their blood, as a routine thing. How distressing is that for you? Once again, you can measure the severity of that distress and be able to look at, okay, what can I do to manage this? And I suppose it's also some of the differences have also been quantified through systematic reviews. For instance, I know people like Skinner and colleagues in 2019 they published a review which was showing that there are significant differences between depression, clinical depression, and the distress that will come from diabetes. So there are differences, but as a result, in terms of, but they're both a similar symptom, because at the end of the day, if I'm distressed, whether it's by diabetes, that's situational too. So for instance, this is where when we're looking at interventions like cognitive therapy, that if I'm trying to understand what is distressing me in this situation, is it my depression, or is it diabetes? I can look at that by looking at what was going on the day, what was the situation. I was just thinking about taking my bloods, and I'm thinking I've done this already this morning. I'm going to do it again later on. This is so you can look at it from a situational point of view, and I guess that is where, once again, treatments like CBT can be very effective.
You mentioned the two different ways of scoring or recognizing, for want of a better word, whether somebody may have depression, if we want to categorize it separately, or may have diabetes distress. So there's a diabetes distress score, which we can signpost the link to. And within that, you mentioned Professor Skinner, and there's Professor Polanski, and these colleagues have really looked into this diabetes distress in great detail. And with things like the diabetes distress score, they're able to sort of locate where the major distress is. But you gave an excellent tip there, and thank you for that. You can yourself think to yourself, what is really stressing me out or distressing me about my diabetes at the moment? And that's maybe a good question for us, if we're living with diabetes, to ask ourselves, what is it about my diabetes which is distressing me at the moment? And if there's nothing, fantastic. If it's issues with food, let's recognize that and see what we can do about it. Maybe it's the medication you might need to look into, but to ask yourself that question. And what would you say in terms of family members perhaps recognizing that somebody may either have one of those clinical diagnoses or the diagnosis of something like diabetes distress? What sort of things could they possibly recognize?
No one wants to be, challenged to say, "Oh, you are this." Oftentimes, this is where problems come between, patients and their family members, and people don't get on very well. But I think it's more around asking questions in a non-judgmental way. Finding out. I noticed this. I'm just wondering what's going on. Or so you're not judging. You're not making a full blown conclusion, because those are the things that really push people away from responding, or acknowledging that there's a problem. I think in its simplest form is being curious, and taking a curious stance, just noticing things. I noticed today you didn't do this, or I noticed today you just looked down. I'm just curious, what's going on for you? Is there anything I can do to help? Those types of gentle, non-judgmental type questions, they really, really help engage someone, because you're not judging them. You're allowing them to express to you what's going on. Oftentimes, people with their diabetes or mental health problems, they already feel judged, and they expect you to judge them. So you're gonna ask me that I haven't checked my blood levels. You're gonna ask me if I haven't gone to see my you can ask, and they already are expecting that, and that's basically what causes their distress. So we're talking about diabetes distress right now. What's causing that distress, over and above having the diagnosis, over and above the challenges of the limitations that they feel that brings to them, and the adjustments that they have to do. They're feeling that other healthcare professionals and or family members are also judging them. And that's the distress that people deal with. So part of managing the distress is really not being judgmental, but really asking questions in an open-minded way, but also without judgment. And that's actually what helps people to engage.
That's fantastic advice, and I think that you also raise the point that people may be judging themselves, maybe feeling blame themselves. Why have I developed type 2 diabetes, or whatever the situation, whatever type of diabetes they may be living with? And they are almost expecting to be blamed and judged. And so having a non judgmental way of approaching, I think, whether that's as a healthcare professional or a family member, is a really important point. So, can I ask you then, with regards to African Caribbean populations, do you think people are aware of the services that are available that could potentially assist them in their mental and mental well-being?
Yes. So interestingly, our Black and Afro-Caribbean populations are aware of the services. And I think the challenge for them has been the bad experiences that they've had in the past with mental health services. A lot of times they've felt let down by services. There has been high rates of dissatisfaction with services. Although we've seen some really good improvements over the years, so there's been a lot of work that's been going on. There has been a lot of changes in services in terms of making them more representative of the communities as well, because that was another challenge as well. But if I come to a service and there's no one like me, how are they going to understand me? So even basic things like that have meant that people have found it difficult to come. The other big thing, obviously, if you think what's been happening over the past 3 years, with the pandemic and the Black Lives Matter activism, racism has been one of the factors that has made people not engage with services, or find it difficult to engage with services. So there are these factors that they are aware of services, and they will utilize them. But what has been said, I suppose, has been for a lot of young people, they've been coming to the services either in crisis or via the forensic pathway. We've got services like the early intervention psychosis, which support people quite early when they develop symptoms that might be symptoms of psychosis. And those services really are meant to help people at early stages, to prevent them from really, becoming, caught up in these services. But people sometimes will not use those services, and you find that they might end up coming via the criminal justice system, and that's what a lot of our young men come through. Now, the avoidance of services, as I said, has been partly due to mistrust, partly due to fears that they will section me or get me locked up, or but also that they will just pump me up with medication. And these are some of the things that then push people away from services. So those experiences, but also the word of mouth. We talk about the grapevine. In our communities, and in our communities, if we don't encourage people to seek help, and we're talking whether in our local communities, people might not end up coming to these services. Same thing as the religious communities. They've got a role, to talk about the importance of people coming seeking psychological help or mental health help. One of the interesting things, our Black community and Caribbean community is very religious. So oftentimes people just go, I'll pray about that, or I'll ask God to heal me, and decide not to actually go and see their consultant diabetologist or their dietitian, or their diabetes nurse. So once again, it's very, very important that, yes, it's good to have a religion and spirituality. It's good to be prayed for, but still, it's also very good to seek that pharmacological help as well.